because this talk on common oral problems in the elderly is really for a group of mixed professionals and paraprofessionals who deal with the elderly, I provided you with a very extensive handout, and we'll be referring to the handout quite often throughout the course of the talk, simply because those of you who are dentists or physicians can refer more specifically to the prescriptions that are included, and those of you who are not dentists and physicians can look more at the explanatory material. What I'm going to try to do today is give you several examples to look at of the different conditions that we'll be discussing. And the first thing that I wanted to show you actually is currently a slide now, and it's a Murphy's Law slide. And quite often with the elderly, when you're dealing with one problem, you find that it has chosen the wrong possible time to happen, and that indeed, if you ignore it long enough, it will get much worse. And while in the frail elderly this is particularly true, in the well elderly it's not quite true to that extent. And one of the things that I wanted to talk about is the fact that, just as you've learned in your different courses that there are various stereotypes of aging and of elderly patients, there's such a stereotype that exists about the oral condition and oral health of the older patient as well. That being generally that the older you are, the drier your mouth, and in addition to that, that the older you are, the more teeth you lose. Well, that isn't true. While we can divide our aging population into a new old and an old group, where the old can be referred to those patients 75 and above, and the new old would be those people coming into their 60s now, you'll look at those individuals orally and you'll find their conditions much different. Back in the late 50s and all the way up through 60s, you'll find that that old group, when you looked in their mouths, more than 55 to 60% of those individuals were completely edentulous, no teeth whatsoever. But we find that now, as you look at the new old, those individuals coming into their 60s now, that level of edentulousness has dropped and is continuing to drop. And recent studies that are being done in different parts of the United States, most recently by the National Institute of Dental Research, they did a senior adult oral health survey in senior centers across the United States, are finding levels of edentulousness at only 45%. And the prediction is that it will continue to drop even more. So what we're dealing with in the future is a series of problems based on the fact that all of a sudden there are all of these old people out there who have teeth and have to be treated with teeth and may have concomitant oral and systemic problems that will present a new challenge to not only the dentist but the other professionals who will be treating this patient. So therefore, we'll start first off with the next and first condition, and that is actinic keratitis. And we'll go to the slide to show you the picture of that, and also let you know that on page 3 of your outline, which you can turn to while we talk about this person, you can read about actinic colitis. And the topic is not only colitis, but also keratitis. And this gentleman, who is in his late 50s, has on his forehead, you can see right here, some brown patches. Now these are actinic keratitis patches, and they are damage that are due to sun exposure over a long period of time in older, usually fair-skinned men. And what happens very often is you'll see this on the lip, and I'll show you a slide of a lip colitis, actinic colitis, later on. But in this particular case, it's felt and believed very strongly that if this is not treated, the actinic keratosis can easily go on to a basal cell, and the actinic colitis on the lip can also go on to a squamous cell carcinoma. So these things really need to be attended to, and you'll see on that page 3 what's recommended very simply is a sunscreen, that anyone who is older, whether they're fair-skinned men or fair-skinned women, are obviously much more prone to sun damage. And in this case, we'll show you another patient who had probably started with an actinic colitis and was not treated and went on to develop a basal cell carcinoma. Now I'll talk about this patient a little bit before I show you the slide because it is a rather upsetting picture. And basically, what the point is of this next slide is to let you know that when you're dealing with older patients, you've got to consider not just what you know professionally, but what that patient's background and experience has been with the disease that you're diagnosing or treating, or the condition or illness that you discover. And in this particular gentleman's case, he's only 68 years of age, and he was told that he had cancer. And no one bothered to explain to him the difference between basal cell cancer or squamous cell carcinoma, the difference between the two of those. And in addition, this man's experience, as far as he knew in his 68 years of life, was that he had lost a mother and a sister to, quote, cancer. Nobody bothered to tell him that this was a completely different kind of cancer, that you remove your basal cell and you're fine. So he heard the word cancer and said, that's it, no treatment for me. And he disappeared into a trailer, a mobile home, for 10 years. And this is how he came out. Okay. This gentleman was obviously severely compromised. His complete loss of his left eye, his right eye mostly deteriorated. His basal cell had already gone into his brain at this point. And when I received the consult for this, he was a hospital patient when I was doing my geriatric fellowship with the Veterans Administration in California. I received a consult that said, loose denture, and went upstairs to the particular ward he was located on and discovered he was indeed in isolation, and that there was a sign on the door saying isolation, and very strange smells coming out. They brought this gentleman in with Pseudomonas infection and lice all over his face, and he had this morbid fascination with what was happening to him and seemed to protect himself mentally from the reality that he was dying, and for 10 years refused almost all contact with the outside world. And it was only because his cachexia had reached such a tremendous point, and you can see from the slide how thin his neck is. You'd have to back up a little bit to be able to see that. There you go. That he indeed is a very, very thin person at this point and tremendously wasted away. But you can imagine what could this man possibly eat at this point. But there were things that we could do, and we did manage to rig him temporary headgear with a very, very soft material lining his denture so that the liquids that he could eat, and his favorite at that point, who cared, cherry candy, could be pulverized so that he could enjoy it. And this is obviously the most tremendously negative kind of situation you would want to have happen from a basal cell. But the fact is that it did happen, and I'm sure there are other basal cells around the country that have happened because of improper management of an older person, communication-wise, on the part of the practitioner. This could have been completely avoided, possibly. But then again, you know, we don't know this man's stubbornness, and perhaps he would not have believed if he had been told exactly the situation and the positive outlook that he could have had for a tiny little spot on his temple instead of having to go through all of this grief. Okay, the next condition then that we're going to talk about is herpes zoster, which is also known as shingles, which is essentially recurrent chickenpox. And you'll find that on your handout described on page 2. In the back of your handout, beginning with table 13, which I believe starts on page 20? No, even sooner. Yeah, page 20 actually is where table 13 starts, and it runs on for several pages. That gives you the prescriptions delineated and the dosages for those people who are interested in pursuing that further, for taking the handout away and using it. But what we'll do with the Zoster and with the other cases is I'll not refer to Table 13. I'll just refer to the pages in the handout where you can find the references. And indeed, if you look down page 2, it tells you when they start to mention the prescriptions to go to the Table 13 and which prescription it is. So herpes zoster in an older person then, next slide, can be manifested in this particular man after healing. This is Mr. Vincent, and Mr. Vincent is a gentleman who is about 64, and he was a nursing home patient who was hospitalized in the nursing home or institutionalized in the nursing home for a stroke. And the problem in the elderly patient with any kind of zoster infection or any other recurrent herpetic infection is that these things can become systemic. In a frail elderly person, a nursing home patient, a hospitalized elderly patient, someone who is already compromised and stressed and attempting to function, this can actually be fatal. And in this particular gentleman's case, he was fortunate, but indeed he obviously suffered very much, as you can tell from the large area of scarring pattern. The next condition is glossodynia. And glossodynia, page 4, burning mouth or tongue of your handout, and stomatitis, the topic after, we'll just lump together so that you can treat them both in your minds at the same time and refer. Now, you can see on page 4 there are a number of causes. You look at number 5, anemia, diabetes, circulatory disturbances, nutritional deficiencies, and we'll talk about some of these and show you some slides, tobacco, alcohol, endocrine deficiencies, GI disorders, including achlorhydria, indigestion or malabsorption, mental depression and neuroses, such as hysteria, and side effects of medication. And at this point, really, I'd like to just point out to you about one particular patient that I had in a screening that we did this summer at a nutrition site. We came across a gentleman who was approximately 72 years of age. And he came in and sat down in our portable dental chair and was very, very quiet. And we looked in his mouth and he had a loose denture. And his complaint was that he just couldn't eat. Nothing appealed to him. He wasn't feeling particularly well. Everything seemed to taste funny to him. All of his food was kind of sour. And when probing a little bit, the individual who was examining him at the time discovered that he indeed had been on Ativan, which is a tranquilizer. Well, at that point, he decided that the gentleman was probably a crackpot. He had been on this Ativan for 2 years. Well, upon further questioning this individual, I was able to ascertain that the real problem was, how long, you ask him, have you had this distorted taste in your mouth? Oh, about 3 months. Well, what happened 3 months ago? Was there any event in your life that occurred? Well, my wife died. Your wife died. What are you doing now for food? Who are you living with? Well, I live with my daughter. And of course she cooks for me, but you know, I just sort of stare at my food. And indeed, in a case like this, it wasn't hysteria, and it certainly wasn't a crackpot. This gentleman had a number of complications. In the aging tongue, changes in its taste buds. The anterior 2/3 of the tongue very often lose their taste buds. And what does the anterior 2/3 of the tongue give you taste for? Sweet and salt. What does that leave you? Sour and bitter. So everything, it's not surprising, tasted sour and bitter to this man. It was an unfortunate coincidence, perhaps, that his taste bud level was decreased to that great an extent, and obviously with every elderly person it will differ. Some people will have none and some people will have an excessive amount. But his was made worse by the fact that this gentleman was on a tranquilizer for 2 years, which is going to depress you a little bit. On top of that, he had probably the worst psychosocial assault to the human mind and body that you can undergo, being death of a spouse, that would also serve to depress him even further, leaving him obviously with everything tasting sour and bitter, no appetite, and depression. This gentleman needed to go back to his physician, be weaned off his Ativan, Probably at this point he needed the exact opposite kind of medication, if any, and some counseling, most probably, so that he could get through his stressful period. He needed also some nutritional supplementation because he wasn't eating well, and if you see patients with nutritional deficiencies, you'll very often find dentures that don't fit. So he could have been helped by a number of things instead of someone labeling him as a crackpot. And that's one of the things that we've got to remember about our older patients, and that's looking at them as not just a tooth or not just a diabetic or not just a depressed person, but look at the whole realm of the dento-medico-psychosocial aspects of that individual and treat the whole patient. Okay. Okay, this slide is more stomatitis, and this one is in a patient who had worn a denture, as so many of them do, without taking it out of his mouth for an inordinate period of time. The days when these folks had their dentures made 40 years ago or 20 years ago, and this one I think wasn't out of the mouth for about 10 years, the dentist didn't bother telling the patients then, you're supposed to take this thing out every night, put it in water so A, it doesn't break, and B, it doesn't distort, and give your tissues a rest every day. Well, no one told this particular individual that, and consequently he has denture stomatitis and an overgrowth of tissue underneath the denture. The next slide is another kind of stomatitis, and this time it's due to an absolute reaction to the monomer in the acrylic of the denture. You can see how absolutely and entirely red this whole anterior third portion of the mouth is, and you can imagine how sore this individual was. Unfortunately, this gentleman also was a stroke patient, so he was excessively compromised because he was already very sensitive, like an allergic person or a pregnant person. An older, frail person is sensitized and very often will overreact to stimuli that other individuals would not react to as strongly. And he indeed had a reaction that kept us keeping that denture out of his mouth. This was not a new denture. This was a reaction that he acquired over time with whatever tiny bit of monomer was left in that denture. And we attempted to put the thing through a pressure cooker again and cure some of it out, waited for it to heal up and put the denture back in his mouth, and ended up he could tolerate that denture for meals only. But at least at that point the redness and the inflammation had decreased enough so that he could wear the denture. Okay, next slide is another manifestation of a stomatitis problem, and in this case this is a combination of things. And on the slide you can see this very pale area which was obviously covered by the denture, and that area is due to this particular individual's iron deficiency anemia. And if you have an anemic palate such as this one has, obviously he doesn't have a ridge that's too great to be thrilled with either, but this man could not wear a denture at all once he developed his anemic problem, and after his anemic problem was treated he could wear the denture, which is very interesting considering all that flabby tissue. But if you'll also look, you'll see a few little red dots. This is a combination of not only the stomatitis, soreness and dryness due to the fact that he had a nutritional problem, but also he was a smoker, and he also manifested some nicotine stomatitis. And sometimes this also will create burning mouth. Now this particular problem is angular cheilitis or angular chylosis or angular cheilitis or cheilosis, depending on where you went to school. And very often this problem, besides being caused by vitamin deficiencies, and we're talking about riboflavin and niacin particularly here, and you can see in the corners of the mouth just how severe his is, but on the next slide you can see that this lady had a denture where her vertical dimension of occlusion was obviously collapsed, and her mouth looks like Little Miss Pucker here in the corners, and that will pool saliva and can also grow candidiasis, as did the gentleman in the previous slide, and will have to be treated as well. Okay. Remember I mentioned earlier about actinic cheilitis on the lip, and this is one of those. You can see it's on the vermilion border of the lip, and it is sun damage. This isn't a mole, and that is one of those things that you're going to want to go ahead and treat with sunscreen to make sure that this individual is not going to have to suffer with a squamous problem later. Epulis fissuratum is another denture problem, and there are a series of denture problems that can occur. And we've been talking also about a number of oral manifestations of systemic diseases, and on page 19 you'll be able to go through the list of common problems, systemic problems of dental patients that manifest themselves orally. Everything from alcoholism, allergies, anemias, atherosclerosis, diabetes and dysglycemias, dyspepsia, endocrine disturbances, hypertension, impaired liver function, intestinal or colon diseases, malnutrition, osteoarthritis, osteoporosis, and rheumatoid arthritis, to name obviously a few. But the perceptive person can pick up a great many clues to a lot of different systemic illnesses by giving a good oral examination. And epulis fissuratum is another one of those problems that can be caused by a bad fitting denture. Now this is another patient, Mr. Roberti, who presented a unique profile, and is another one of those patients that I want to tell you about because he also presented with an atypical affect. And in this case, it was that the man was not a pleasant human being. And one would think, well, is he just stereotypically an old grouch? Or was he always an old grouch, and now that he's old, he's just more so a grouch? Or was there some other kind of problem? And upon treating this individual and being told repeatedly about other individuals' experiences with him and how angry and nasty and mean he was, and finding that no matter how many times and how much of an effort I made to bend over backwards to be as considerate and kind to this man as possible, that he was not giving me common courtesy, that I really finally confronted him with it. This is not a senile, confused human being, and if someone is behaving poorly, no matter what their age, to you, you're certainly within your rights to confront them and say, what is the problem? Can I help? What am I doing that upsets you, for example? Is it my fault? And what ultimately happened was that the man suddenly unloaded. This is another case of depression that just manifested itself differently. Depression can manifest itself obviously as confusion, dementia, or as we saw earlier, as abnormal oral conditions. And in this case, it was real personality change. And this gentleman was in a nursing home and had had a diabetic removal of one of his legs because of his particular problem with circulation, and was not thrilled about being in the nursing home, and finally let on that he had lost a daughter and a wife in a car accident about 20 months earlier, and that nowhere along the line had anyone been there for him to talk to. He had not had any psychological counseling. He had not even seen a social worker. He was just in a nursing home and had this tremendous loss occur in his life. Obviously nobody was coming to visit him. And this tremendous change left him so angry and so depressed, and he was very unable to deal with any of this, when some counseling would have helped him, and he was also not on any medication that would have helped him cope a little bit better either. And consequently, if you're not happy, if you're depressed, if you're angry, then you're not going to be real careful about what happens in your mouth either. And the next slide will show you that this particular individual had dropped his denture and broken it in 2 places and continued to wear it. Well, if you wear a denture like this, what you ultimately can end up with is tissue that looks like this. And this is the epulis fissuratum, and this is the little excess tab right here. And also, let's see, there it is right there. And at this point, when you have this much, this has to be removed surgically in order for the denture to fit better. And you know, depending on the weakness of the patient, the frailty of the patient, the medical condition, you might or might not choose to go ahead and have this kind of thing removed, but you certainly would need to go ahead and make a new denture for someone like this, or have a new denture made for a patient like this. Other kinds of dentures can cause epulis fissuratum. They don't have to be broken, they can just be poorly fitting. And if obviously a patient has been walking around with a 20-year-old denture in his mouth that has never been relined, never been seen by a dentist, and he's never had an oral cancer exam, who knows what could be going on in that mouth under that old denture. Looking at the next slide then, we can see that just as we've all been lectured about plaque on the mouth, plaque on the dentures is another common occurrence, and I don't believe that this individual had his dentures out of his mouth for about at least 10 years. And you can see that all of this white stuff is hardened plaque. This is all calculus, and it's formed at this point all around the teeth, and besides being ugly, you can imagine the unfortunate odor that this person also experienced. At this stage, something very strong like a walnut shell blaster or something like Lime Away, almost full strength, would be needed to remove the calculus from this kind of denture. But my best guess is that with this kind of buildup on the tissue surface of the lower denture, these things don't fit anyway and need to be remade. The next slide is of a patient who believed in relining his own denture and managed to do it actually twice. You can see this little darker color around the outside edges, and that is the store-bought reline that he used because his didn't fit and he didn't want to go to the dentist. Then a couple of years later, after he decided that that wasn't working real well, he got this new technique where he filled in this extra lighter stuff in the center, and that is what is known as a toilet paper reline. He went to the men's room and got himself some toilet tissue and wet it down and stuck it in there and kept that in there, replacing it obviously every so often because it hasn't disintegrated completely. But you can imagine the palate underneath this denture. And again, if there's one thing you come out with from this, it's anybody with a denture who's old needs to have it considered that unless that's a new denture, that denture most probably has not been looked at or examined and needs to be, as well as the oral condition of the mouth, because of the increased incidence of oral cancer in the elderly, particularly elderly men. Okay. The next topic then that we're going to address is herpes. And herpes, we'll talk about labialis as well as a reminder that there are different manifestations that you'll see. And in the elderly, just like we mentioned before with herpes zoster and it becoming systemic and tremendous fevers and even being fatal, if you have an elderly person who's immune compromised in any way, then the eruptions that you're going to see, whether it's primary herpes or secondary recurrent, can be quite severe. And we'll look at the first case, and you'll see that this eruption actually is secondary. This is a recurrent herpes labialis infection, and this individual, you can tell from the slide, this is a younger person. But as an example of what you would generally see, what you can see on the next slide, this is a primary in an older person who's not that old. This is maybe 35. But in an old person who is immune compromised, this can be very, very systemic in terms of the fever and the sickness. And this individual is a young person who's got leukemia, in an older person who has leukemia, and you do know that in the older leukemic patient, they're susceptible to very, very many things and quite often end up dying of pneumonia. This particular kind of initial herpes response can happen in an older, very severely immune compromised person. Okay. The next slide is something I'd like to warn all health practitioners about, and that's herpetic whitlow, or Whitlow's finger. And that is, don't play around in somebody's herpetic lesion without gloves on. Not only is it thought that we'll spread that lesion on that person, but you can also spread it on yourself. If you ever want to see just exactly how microscopic your own lesions on your hands can be, stick your hand in a pan of isopropyl alcohol and you will find the most unbelievable burning sensation all over different parts of your hand. And in any one of those little burning parts, the herpetic virus can intrude in your tissue and leave you with something like this. And certainly dentists, not before this, have suffered from those kinds of things, and I can't stress enough the importance of examining anyone orally with gloves on. And that's also because you don't know if someone who has a history of herpes labialis has a prodromal variety, which may display itself before you are aware that there's herpes there in an overt eruption with tingling sensation or with just a pale redness. And you could be passing it to yourself or, again, spreading the lesion on the patient before it's fully erupted just by touching. So again, one more reason why gloves are so important. Okay, the next case, we're going to talk about squamous cell carcinoma. And certainly on page 15 of your handout, you will see a chart of oral malignancies seen by dentists. Well, squamous cell carcinoma, very often, and I'll give you the most common sites to look for squamous cell carcinoma: the floor of the mouth and the lateral posterior borders of the tongue. When you look in someone's mouth, whether you're a physician, a nurse, or another kind of healthcare practitioner, where do you look? You look at the top of the tongue, and you look straight back to the pharynx to look for redness, and maybe to see if there's tonsils. Maybe you'll look at the roof of the mouth, and that's about it, when the most common site for oral cancer in a population with it increasing as much as it is in the elderly is floor of the mouth and lateral posterior borders of the tongue. And you can't examine those areas without a light and without having someone stick out a tongue, grabbing it with gauze, pulling it out and to the side and directing that light on both sides of the tongue to that posterolateral border. And that is the only way you're going to be able to see lesions in that area. And very often things that could be picked up by patients who are more inclined to go to physicians and other healthcare providers than dentists get missed. And certainly in the world of dentistry, dentists more and more are beginning to look in those areas for those kinds of lesions now that it's become such general information that those are serious problems. Well, let's look at this particular gentleman's case. Next slide. Intraorally, this is Mr. Shepard's mouth. Now, squamous cell carcinoma is not like having a bruise. It doesn't hurt like most cancer. And in his case, he probably knew there was something seriously wrong with him, and he chose to ignore it and ignore it and ignore it until it became this bad and eventually showed up, had to have his maxilla more than bisected. You can see that the border of the lesion is here, and we had to take it off all the way over to here. And there will be probably more and more patients like this coming into dental offices who have had their surgery or who haven't had their surgery, who are going to need some help from the dentist. And I think that we'll see general dentists more and more beginning to help patients like this with their obturators and relining their obturators periodically so that they fit better. The next case then is Mr. Benton, and we're not going to talk about cancer with this individual. And yes, that thing that you see on the side of his cheek there is a tumor. This is a lipoma though, and not the problem. But I wanted to show you what the man looked like and then show you his hand. And the telltale brown finger, or fingers, and the other side of his hand is worse. And obviously this is a smoker. This is a stroke patient in a nursing home. One of his few joys in life was to smoke, and he certainly did. And what it resulted in is an unbelievable case of not black but brown because of the nicotine hairy tongue. And you can see the overgrowth of the filiform papillae all through here. And you can imagine also the gentleman's breath. Well, next slide. No one ever told him that he could help himself out by brushing his tongue. And if you will, look in your handout, you will find on page 7 of your handout Langlay's Miracle Paste. And Langlay's Miracle Paste, this pumice, toothpaste, and mouthwash mixture certainly serves as a tremendous aid to brushing the tongue, and this stuff will come off like rug fuzz and result in a normal tongue. Certainly an improved breath, certainly improved taste sensation. You can imagine what he's lost in the way of taste sensation. Okay. The next thing that we're going to talk about is xerostomia. And again, while you're on page 7, you can look at the bottom. And again, causes of these things. In this case, most commonly, we've got radiation, pharmacologic agents, and disease process. Now, it's a common stereotype that's been held for a long time that old people get drier as they get older. Well, all the research that they did on that says that your salivary glands atrophy with age, and the reason you have dry mouth as you get old is because of that. All that research was done 30 to 40 years ago on individuals who were not real healthy people and quite often were on medications. All of the current research that's been done in the past 10 years indicate there really is no normal physiologic change in salivary glands that accounts for an absolute decrease in saliva of any significant degree. That people who have dry mouth for a reason. More often than not, it's due to the drugs that they're on. And almost any drug you can think of. Antihypertensive, diuretic medications, diabetic medications, sedative hypnotics, tranquilizers, on and on and on and on. All of these things cause dry mouth. And if you look at the preponderance and the use of these things among the elderly, you'll find how common it is. And things that need to be considered are obviously changes in these medications. Some are not as bad as others, and physicians need to be aware that they can change those medications, and sometimes that has to be pointed out to them by dentists or dental hygienists who find such a tremendous drug history. And also, there are other kinds of ways in handling these problems. Looking at the next slide, there we go. Additional causes for dry mouth, and you can also find it on page 8 of your handout. Depression, dysglycemia, diabetes mellitus is really, there's some kind of connection between salivary function and diabetes, and very, very often we'll find dry mouth. Not always, but often. Of course, lupus and rheumatoid arthritis have the same connection. And very, very often we'll see patients who come in with these kinds of problems and they're ignored. And we can do something about it. We'll look at the next slide. Signs of xerostomia, again on your handout. And you can see, obviously, amputation caries, atrophy of the epithelium, inflammatory fissuring. That tongue I showed you is the very first slide, about 5 slides back. Inflammation and infection of salivary glands as a result, and candidiasis. All of these things can occur together. And when you see them, it's one of the first things you think is this a xerostomic problem? Ask the patient, is your mouth dry? Sometimes the mouth is unbelievably dry, and sometimes it's only slightly dry. And there have been really no good measures to tell whether someone has dry mouth. The old technique was you take your finger, you run it along the cheek, and if your finger skids along the cheek, then boy, this must be a dry mouth. Well, that's obviously one method. With that kind of a dry mouth, you could ask the person, I'm sure the person will be able to tell you, sure is dry. But for more subtle changes, you might want to try this new tongue blade technique that some people are trying, where obviously if the saliva, you just stroke it once, the tongue blade along the buccal mucosa. If the saliva pulls up on the end of the blade, the person has adequate saliva. If you run it along and the saliva isn't very much on that blade at all, it's on the edge, the very edge, barely going over the border, then you realize that this person probably has some kind of salivary problem, even if they don't realize it, and you might want to prescribe something. Looking at the next slide then, we can look at symptoms of xerostomia in more detail. People will burn. They will be sore. They can be ulcerated. Dentures will not stick up. They'll be obviously dry if it's severe enough, and can have taste and smell abnormalities. Remember the gentleman I told you about who was on the Ativan? Obviously, Ativan as a tranquilizer is one of those drugs that's going to cause some dryness of the mouth, and his was very pronounced as well, and it altered. In addition to his salivary bud decrease, he also had altered function from depression, and indeed from this drug as well because of the dry mouth. And lastly, on the slide, we can see stickiness of tongue to palate. You can tell a person who's got a dry mouth when you hear them eat. They do that. You can always tell. And this is one of the things that makes a lot of people in their life very socially unacceptable, because just of the unpleasantness of their eating noises, as well as the appearance of trying to watch someone who can't get enough saliva together to help start the oral phase of digestion. Okay, next we see just one example of the many artificial salivas that are available on the market, and this particular one is Xerolube, but in addition to Xerolube, we've got an entire list, and you do have the list on your handout. It's on page 11 so that you don't have to take notes. And in this case, you can see a number of them. And VA Oralube was the one that was initially developed by Ira Shannon in Houston and started the whole sequence of events. They're all sodium carboxymethylcellulose, usually with some sort of ingredient that's added, hopefully to give the thing some consistency. The problem with salivary substitutes is that you ask any person who uses them and they'll probably tell you they don't work. I'm just as happy carrying around a squirt bottle of water and just pumping the stuff in my mouth every chance I get. And the reason for this is because these things don't last. They last for 5 minutes. Well, the Danes have been doing research for a number of years now and are beginning to have headway at long last with some of these artificial saliva products with using mucin. And they're talking now that the products that they're testing will last for an hour and a half. Think of what that means with someone who has very severe stomatitis, whether it's from cancer and the chemotherapy they've been on or radiation that they've been on, that cannot go out and eat a meal. I mean, how much of our lives, our social interactions, are done around eating and drinking socially? And these individuals can't do that. And if they can get something that's going to last in their mouth for an hour and a half, this could open a whole world of social interaction for these people. So hopefully we'll be seeing something of a decent, long-acting saliva substitute shortly. I can't say when, perhaps in the next year or two, but obviously it will have to be tested in this country as well before it's accepted for extreme use. The next slide, we'll go ahead and talk about radiation caries very briefly to show you this mouth and to remind you especially of the new changes. And there are new changes in the treatment of patients who are going to have any kind of radiation to the head and neck. And that is very simply that if those individuals can get to a dentist 2 weeks before their radiation therapy is to occur, then any teeth that are beyond hope can be removed. Any teeth that need to be restored or cleaned can be restored with restorations or fillings or crowned or whatever needs to be done, and then cleaned. And that person can go in to radiation therapy knowing that even if there is a complete loss of salivary function due to extreme radiation, that person with proper home care might be able to retain those teeth for the rest of his or her life. And it used to be that what would happen is if it was the radiation therapist or the ENT surgeons or whoever was responsible for the care of that particular individual, who knew that radiation would be incident to that area of the face, send that patient down, usually in a hospital, to the dental service there, where there may or may not be anyone more than just an oral surgeon, and say, take out all this person's teeth because we're going to irradiate this person. Or very often, as in the case of this gentleman in the slide, not even bother to send him to a dentist and just go ahead and irradiate. And either in the old days all the teeth would be removed or nothing would be done, and here was a nothing that would be done. Now this gentleman was lucky because we were able to restore all of those teeth without having to remove any, and osteoradionecrosis is a very serious concern in someone with post-radiation problems, and if you have to extract teeth in these individuals, you do so with a real cautious approach. They try and save everything if you possibly can. And essentially these individuals for the rest of their lives with teeth need 0.4 stannous fluoride, 10 to 15 drops in a little styrofoam tray every single day of their lives for the rest of their lives, 20 minutes a day, and then removing the tray, this gel, and not having any water for at least half an hour. And they must have meticulous home care and brushing and flossing, but they can keep those teeth because dentures are only about 20 to 30% as efficient in chewing as your own dentition, and there certainly is nothing like your own teeth. Next slide. Okay, we'll talk about candidiasis. Now we've mentioned candidiasis already, and we've got a number of pages in your book, 5 and 6 most particularly refer to candidiasis in your handout, and the appearance of it, the treatment of it, etc. And the important thing to remember is that candidiasis can accompany a number of things we talked about. We talked about nutritional deficiencies, an angular chylosis in the corner of the mouth with pooling of saliva and Candida just adhering to that. We talked about immune deficiencies in patients and Candida being present because of that. We talked about, in addition, dentures that hung around in mouths without being removed for years on end, and Candida loves to grow under those, and indeed can present a number of problems, and we'll look at a few. First case on the slide. This is severe erosive candidiasis, and you can imagine that you remove this white stuff and underneath you're going to bleed and peel, and this is an extreme case. You probably won't see a lot of it. Mostly you'll see this kind, which is mild inflammatory candidiasis, and you can see it's swollen, it's red in places, and this is one of those that was under a denture that was just left in the mouth for many months before it ever came out, and the swelling can be quite excessive. Treatment of this, next slide, can be with chlorotrimidazole lozenges, and the old technique was you either gave a rinse or you prescribed a vaginal tablet and had the person suck on them. And if you've ever worked in the Veterans Administration, and I know a number of people have, that you'll find that you can't get a veteran to suck on a vaginal tablet, and it becomes very difficult. The chlorotrimidazole lozenge, and Michael X is just one brand that's come out, is very new. It's only been out for a few years, and it is working very well. And you'll find from your handout that the important thing is that you've got to soak the denture in the nystatin solution and then put the powdered material in the tissue surface of the denture so that you don't constantly reinfect the individual by putting the same Candida-ridden denture back in the mouth. Okay, if we'll look at the next slide then, we'll go on to the traumatic ulcer. And the traumatic ulcer is on page 12 of your handout and is dealt with quite excessively there. And in this case, you're looking at something that doesn't have the usual appearance of a traumatic ulcer, and some of you will recognize that as an aspirin burn, which again is a reminder about your management of the elderly patient and your communication techniques. They have a sore tooth, they take an aspirin. To them, taking aspirin could mean either taking it orally like they're supposed to or putting it next to the sore tooth and hoping it'll get better, in which case they end up with a tissue burn like this. Well, the next slide I want to show you looks very similar. I'd like you to look at this one more time before I change slides so you get a picture of it. And you can see that it's in the buccal vestibule. The next slide, something very, very similar on the floor of the mouth. This is not an aspirin burn. This is not a traumatic ulcer. This is squamous cell carcinoma. And this is why you've got to lift up that tongue and look underneath it. And you wouldn't know. You wouldn't know the other one wasn't a squamous cell. What it means is the history is everything. You see a white patch, you ask if they've noticed it. If it's sore, that's a big clue. If they had something that they put an aspirin for, or they ate something too hot or whatever. But traumatic ulcers, never forget your differential diagnoses. Here's another type of traumatic ulcer. In this case, it's a denture ulcer caused by a denture that didn't fit. You can see this particular individual doesn't have very much bone left and was wearing a denture that didn't fit, probably needed a soft reline that was consistently replaced every so often to keep this denture working, and obviously this is probably very, very painful. If you see a patient like this who's had a stroke and is aphasic and can't tell you that it hurts, unless you look, you don't know. Next in our long series of traumatic ulcers is this one in a lady from Denver. And traumatic ulcers can manifest themselves in a variety of ways. This is the most typical presentation of a traumatic ulcer. And it looks a little bit chronic, like it's been around for a while. And people who saw this weren't too sure of what it was, suspected that it could even not be traumatic because she couldn't remember whether she bit her tongue or whether it was traumatic. And they thought, well, maybe this is some kind of carcinoma we need to have a look at, and biopsied it. 3 weeks after the biopsy, this is what the lesion looked like. Why? This is a diabetic individual with impaired healing, impaired circulation, and this obviously is going to require some extensive work to get this to close up and resolve. And again, if you don't take a good history, you don't know the kinds of problems. And diabetes in the mouth, this person probably also, with this kind of slow healing process, probably also has periodontitis problems as well. The next slide is of a very unusual kind of aphthous ulcer. Most aphthous ulcers occur in series of little bubbles. And again, the etiology, one doesn't know, usually has some kind of emotional or stress component to it. Page 13 and 14 of your handout, the aphthous ulcer is treated quite extensively. But this particular kind is a large and unusual erosive lesion. And again, could be trauma lesion, could be a cancer lesion. You really don't know until you take a good history, find out what's happened before, and sometimes you even have to biopsy things you'd rather not, just to be sure, especially when something is on the floor of the mouth, as this one is. You want to be better safe than sorry. On the next slide then, we'll look at another disorder that occurs in elderly patients, particularly if they're arthritis patients, if they're immune-compromised patients. And this is usually a dermatologic condition. You can see the white striae, and in this case, this is Lichen Planus. Page 16 and 17 of your handout delineates it fairly well. Very often it's dermatologic, it's on the trunk, the arms, and the legs, and steroids are the recommended treatment for it. But in 65% of the cases, the only lesion is in the mouth. So one really wants to be very careful and pick up these kinds of things, especially if the person presents with pain and discomfort, which sometimes happens, and there's localized lymphadenopathy. Okay. Next slide. Hypersensitivity in the elderly, one would think might not be a problem because as they age, the pulps that are in the center of the teeth, and usually so large because of all of the use of teeth over the years, recede and more dentin is laid down, and teeth are supposedly less sensitive. This particular patient, however, has been brushing with a hard toothbrush as if his life depended on getting this tooth clean, and the result was that the tissue ran up the tooth, and you can even see it's beginning to happen on this tooth right here next door, and even this one over here. And very often a person will give themselves a periodontal condition just because they're brushing too hard. And in this case, this older person did that, and this one was very sensitive. And you'll know there's a lot of discussion going on about using fluoride gels to decrease sensitivity in these teeth, about using glass ionomer restorations and other tooth-colored restoration materials to fill in this area to make them less sensitive, and even iontophoresis and other electric stimulation to decrease sensitivity. And some of them work and some of them don't, but know that if you do see someone who's complaining about cold air hitting a tooth or anything he or she eats making a tooth sensitive, look for something like this, as well as decay and infection. The next slide. This is something you may see in stroke patients a lot, and in this particular patient it's all along here. You can see how red and sore everything is and covered in plaque. The rest of the mouth really doesn't look like that, and the reason for this is something called affected side neglect. It's not only because if a patient has had a unilateral CVA that they really don't focus in on the visual field across the other side of the mouth, but they often forget that that part of their body is even there, and they could be doing a beautiful job cleaning their own mouths and completely miss this side. And it would be a shame if this individual had to lose all of these teeth because they weren't cared for and their periodontal disease got to be severe, when all that's required is a partial denture in the upper so that he could have chewing going on this side of the mouth. The next slide is another occurrence that happens with stroke patients, because very often they'll put stroke patients and other kinds of patients as well on phenytoin derivatives or other anticonvulsants. And dilantin hyperplasia or phenytoin hyperplasia, this is called, is usually thought to exist in little kids who only have epilepsy, but believe it, it happens in the elderly as well, and something like this is going to have to be surgically removed. And if you're dealing with a frail person, such as a stroke patient, you don't want to have to challenge that person systemically with removing this kind of junk. And lastly, patients who are in institutions, whether they're hospitals or nursing homes, it is a good thing to encourage dental laboratories to put either names or social security numbers, hopefully name and social security number if there's enough room, in dentures. You can do this very easily yourself in even running through an entire nursing home with a little drill to remove some acrylic. You don't have to embed a tissue typed piece of paper like this one. You can use an indelible marker such as one of these little pens that work on slides, and then just cover it over with clear acrylic nail polish even. And there's a whole entire variety of methods for putting names in dentures so that these things don't get lost, and the expense to the patient and to society in general, who have to bear some of the burdens, such as the hospital who loses the denture because the name is off it and it can't, and finds it, doesn't know who it belonged to, they don't have to be remade. I think that basically the message of this whole talk has been that no matter who you are as an old person, you should be able to receive the same kind of good oral health care that this particular elderly individual receives, and that means it's incumbent not only upon the dental practitioners, but other practitioners and other allied health personnel who see these patients to take a good, long, hard look in their mouths and make the appropriate referrals. Thank you.